posterior subcapsulars and all are no longer a problem with that.
So that's why I said only very, very dense. Very dense is actually
posterior polar, every cataract.
OCTs are nowadays working very, very well. Very well.
Yeah, we've come a long way. From the
only thing is expense.
Even a
so
speck
if
of
you're
a
ready
cataract
to
used to block
spend
it
as much
earlier.
as you want, you can forego even the hardest of the cataracts with an optical biometer. So that's there.
Good morning. First of all, let me thank you for giving up a Sunday morning to be here. So all of you are sitting here, a very precious audience for us. And feel free even to interrupt me. I'll be talking about IOL power optimization, and that is how to get the best possible lens power for your patient. Now, is there really a problem? We have a lot of formulas available. So given that we have measured a good keratometry, we've got a good axial length, we put that into the formula, and there are so many of them. So do we really have an issue here? Do we not know how to measure IOL powers or calculate them? So now we know that each IOL formula has its own limitations, and I'm going to give a small demonstration here of why these limitations lead on to statements such as SRKT is good for a long eye or Hoffa Q is good for a short eye. The reason these statements are there is that if you were to put in the same values and calculate in a different formula, you might sometimes get markedly different results. And then you're in a fix, you don't know what to choose. And if you choose incorrectly, and if the patient is really, anxious about his results, and bear in mind that a small miscalculation here, and you're going to leave the patient with a refractive error for the rest of his or her life. So it's a really important thing here that you get it right on. So you need a solution to improve things as far as IOL power calculations are concerned. Now, optimization is that solution. So when I say optimization, I would like to clarify what I mean by optimization. So there's not much scope to change, things in an IOL power formula, except for one thing. And for to look at that, let's pick up the box and look at the side of the box, and you'll see the A constant mentioned here. Now the key word to notice here is that it's a suggested A constant. The manufacturer is telling you that this is a kind of a starting point where you go, and then you need to change things around. So the A constant or the lens constant is the only thing you can change to make your output better from a given formula. What it means basically is that you have to feed in your own data, and then after a while, if you have changed the constant, it then starts to reflect what's actually going on in your practice. So all sorts of systematic errors are taken care of. For example, if your keratometer is off by a little bit, you don't realize it, but if you've optimized it, then that little bit of systematic error is included in the new A constant that you've got. So even with a slightly out of whack keratometer, you can still get the best possible results as long as the error is consistent and systematic. What are the inputs that you need in order to optimize? So there are a couple of factors that you must maintain records for these. You need to have the keratometry and the axial length that you have measured. So don't just throw it away, keep a record. You need to know what IOL power you have implanted in a given patient and what model was used. Now the model is important because you need to optimize separately for each model. You also need to know what the post-op refraction is, and this should be a stable refraction. You cannot do a refraction at 5 days or a week because that's going to change. So minimum recommended would be maybe about 3 to 4 weeks, and a good refraction, because if you leave it to the optometrist and that optometrist is not a professional person who's made mistakes, if there's a lot of variability in your post-op refractions, then you might get a lot of variability in your IOL power optimization process as well, which will defeat the whole purpose. You could back calculate. That is one way to optimize. So this is an equation representing how you back calculate for the surgeon's factor for the Holiday 1 formula. Now the problem is if you miss a single bracket here, it's gone haywire. It will not give you a result. Or even worse, it might give you a bad result. So, like this cat, you prepare everything, you get ready, you make the measurements, you got everything in place, you're feeling good about it. This is a jump you can make, right? You have the maths, everything is there, and this might just happen. So the other thing, the better thing to do would be to use software. Now most of the biometry machines would have onboard software, so you can just go back and put the data in your biometry machine, including the very old A-scan machines. I used a biomedics a long time back, and it had a place where I could fill in the refractive data, and it pretended to give me optimized values. Later on, I found out there was some formulas which were miscalculated in that machine, so I gave it up. So the other thing you can do it is you can ask me to do it for you. I'll very happily do it for you, and for that reason I'm sharing my number as well as my email. So just send me the data and get in touch with me, and I'll optimize the constants for you. Now when I say optimize the constants, you have to optimize also for individual formula. So SRKT, you have to optimize the A constant. If you're using holiday, you have to optimize the surgeon's factor. If you're using Hoffer Q, for example, you have to optimize the PACD. And once you have done that, once you have optimized the constants individually for each formula, you will find that the differences that emerge in the formulas, like I showed you in the beginning, start to disappear. So even across the ranges, you have now the formulas start to predict much more closely placed values than before. So that is a definite benefit you will get. Alternatively, you could go beyond convention and go for dynamic IOL optimization. This is a commercial solution we have developed. So what DIO does is, it will do everything at one place. It will maintain your database, it will perform the analysis, give you an optimized power, which is a single power you can use without having to think about which formula is better for which situation. And the best thing is that everything is automated. It's an Excel sheet, so you can just keep it on your laptop and work with it. The question here is it worth the effort finally to optimize? A lot of people I have met and I've talked to them about optimization, and they say we are getting perfect results, we don't have any refractives at all. And that is the point I usually stop talking. But if you feel you do occasionally get refractive surprises, then it's worth looking at Dr. Warren Hill's website. I checked it yesterday and the data remains the same. Modern accepted values for accuracy would be like a half a diopter of prediction accuracy for more than 70% of the surgeries. So like if you're doing 10 surgeries, on 7 of those you will get less than half a diopter of error, which is a reasonably good value. So this is the global standard we are looking at. Now we analyze DIO and we hope to publish the results later this year. What we are getting with DIO is half a diopter for more than 85% of the eyes, and then for 99% we are within 1 diopter. So this has increased our confidence levels quite a bit in the kind of outcomes we can promise to our patients. So the take-home message would be that do optimize. It is worth the effort. Do it on your biometry machine or send it to me or find some other way to optimize, but you must. So with that, I thank you, and I would love to take questions if there are any.
Saurabh, this WhatsApp and email which you very obligingly provided, is that free or are you going to charge for it?
I would love to charge for it, but as of now it is free.
Thank you very much. It's important for the audience to know that. Please utilize the services.
WhatsApp is free. So no, my services are also free as of now.
That's important for the audience to know that.
So DIO is a commercial thing, but optimization I'll do free for you. Not a problem. I love doing this.
Any questions from the audience, please? In